On behalf of the American Heart Association, I would like to welcome you to the second session of today's Pain Management Summit, Perioperative Pain Management. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most issues can be solved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. Throughout today's presentation, you will have the opportunity to submit text questions for our presenters using the question feature on the bottom of your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end as time allows. By email tomorrow, you will receive an invitation to complete our feedback survey. This presentation will be recorded and be made available within the coming weeks at heart.org/pain management. It's my pleasure to introduce our speaker for today, Dr. Kim Maurer. Dr. Kim Maurer joined the Oregon Health and Science University Department of Anesthesiology and Perioperative Medicine in 2006 after completing both a pain fellowship and a pain research fellowship at Stanford University. She is the medical director of the Comprehensive Pain Management Center and vice chairman of pain management at Oregon Health and Science University. Her publications include work on guidelines for pain management and work on opioid management. Dr. Maurer is certified in both pain medicine and anesthesiology and also works in inpatient pain management. She also recently completed her master's in business administration. Dr. Maurer, the floor is yours.
Thank you, David. I just wanted to start by thanking you all very much for having me here and for coming to this webinar. So we are going to kind of do a little whirlwind around the world tour of perioperative pain management. And before we start, I just want to acknowledge that there are lots of different ways to do perioperative pain management. And I don't know that there is a best or a worst. I do know that every institution does it a little differently. And I think the important part is to know what's out there, to know the literature, to pick what works for your institution or your practice, and to find what works best for your patient. And the beautiful part about perioperative pain management is that there is an entire host of things we can do. So there is lots and lots of choices of things we can do in perioperative pain management. So I'm going to kind of skip around. It might feel slightly hectic because we're going to do little bits and just kind of touch on multiple topics. So it won't be a deep dive into any one thing, but kind of a glossing over of just a lot of the different mainstays and the main things people do for perioperative pain management, kind of from my perspective and the perspective of working here at my university. Okay, so we're going to start off with my disclaimer. You can read that there on the screen. That's a disclaimer for me and for the American Heart Association. And I have no disclosures, so I wanted to put that up there as well. Now we talk about pain. I think the very first thing in any pain talk is often the definition of pain or the types of pain. So an important thing to remember is that pain is still divided into two big categories. We have acute and we have chronic. And the etiology and the timing of when acute goes to chronic has varied over time. It gets shorter and shorter, meaning that we now know that acute pain is less and less and less time you need to have that acute pain before it can really potentiate into a chronic pain situation, meaning that the pathophysiology is developing in the background that you could have chronic pain. When I first started training, it was 6 months until we called it chronic pain if you were having pain, and then it dropped to 3 months, and it keeps dropping and dropping. And I would say that most people now say that acute is about 4 weeks, 4 to 6 weeks, and then after that, it's chronic pain. Now, on this slide, I'm just going to try and talk to you about chronic pain for a second. Even though perioperative pain is often acute pain, which is a lot of inflammatory type pain for the most part, not always, but a lot of it is. In chronic pain, we kind of have 5 main categories we look at. And you can have what is called acute on chronic. So when someone comes out into the operating room or the perioperative setting or the PACU, they often can have pain that is an acute pain on top of their chronic pain. So I think in any management of perioperative pain, it's essentially very important that you also understand their underlying chronic pain because you're going to kind of be treating both pains. So the 5 categories are nociceptive, neuropathic, visceral, cancer, and somatic. And the definitions, you can have a talk about each of these, an individual hour talk, because the definitions are very complicated and very different from each type. But the main thing to remember is think of viscera as all of the linings of our internal organs, kind of the capsule of the liver, the linings or coverings of various organs like the colon and the stomach. And the visceral means kind of those internal, very deep structures. Cancer pain is what it is. It's cancer pain. Somatic refers to soma, Latin for body, meaning to our musculoskeletal system, our tendons, our ligaments, our joint spaces. Nociceptive means it is caused by a nociceptor, and neuropathic is what it means. It's a nerve type pain. And we divide neuropathic usually into peripheral or central neuropathic. Central being something like multiple sclerosis, Sjogren's, ALS. And then peripheral is something like painful diabetic neuropathy pain. Now people say, all right, pain is just pain. It's a sensation we feel, right? It's not deadly. It's not going to kill us. It's uncomfortable, but who hasn't all been uncomfortable for some reason in their life? But really, there are effects of uncontrolled pain beyond the sensation. So even if your patient says, hey, Mrs. Smith or Dr. Smith, I can handle the sensation of pain, we still want to kind of control pain, even if the sensation is not bothersome to our patients, because there are physiologic effects of uncontrolled pain. Some of these are listed to the side here. We can see a lot of atelectasis. And where that comes into play is the development of pneumonias and slower recovery. So when people hurt, especially in their chest, their upper back, the thorax, they don't breathe as well. This leads to your lungs not being as dilated or exposed or filled as they need to be after a general anesthetic in the PACU, and that promotes to pulmonary dysfunction. We know that uncontrolled pain can lead to more of a thromboembolic state. It almost looks like cancer, where you become more clotable, if that's a word, clotable, but you become more thrombotic prone. We also know that you're already at risk for DVT when you're in a hospital because you're not moving around as much, you're in bed, you're being more still. And so if we add that to uncontrolled pain, which makes you even more prone to a clot, it's not a great thing. We know that uncontrolled pain decreases our immune function, something we never want when we're in the hospital or not. We know that it affects sleep, not a good thing. We all do better when we have a good night's sleep. Anxiety and depression are worsened by pain. We always say pain, anxiety, and depression are like the chicken and the egg. I don't know really which one comes first and which one comes second, but they're all tied in together. It leads to us being deconditioned because we don't work out, we don't go to the gym. It leads to stress, and often leads to financials that aren't as good because you're not working because of pain. Having pain, back pain, and number two, headache are the two most common causes people tend to miss work. And then uncontrolled pain can actually, in some studies, lead to other comorbid illnesses just by having uncontrolled pain. You promote yourself to develop other illnesses. Those are some newer studies that are out. So people say, all right, let's look at the acute pain setting. So Dr. Smith sees their patient, let's say Jane Doe, in the operating room and the post-op area for pain after an appendectomy. So her appendix has been taken out. It was done laparoscopic. There's a very small laparoscopic incision. Why does the inflammatory pain, the acute pain, hurt? Let's say Jane has no chronic pain. She has inflammatory pain from her laparoscopic incision. Why does it hurt? Well, this is like a cartoon, truly at a cartoon level. Inflammation hurts for many reasons, but the simplest explanation, and really probably one that I can give because I'm not a basic scientist at this level, is that after surgeries or whenever we do anything physical or strenuous to the body, we get fluid, right? We have fluid retention, we have a buildup of fluid. This leads to swelling, common phenomenon after we have surgery. And it's as simple as the swollen tissues that are swelling up push against your nerve endings, the corpuscles of the nerves, which are sensitive. And then this pushing up against stimulates a nociceptive release of prostaglandin. And prostaglandin, amid many other things, we used to think in the 80s it was just prostaglandin, but now we know it's like this inflammatory chicken soup that happens. All of these neurotransmitters and vasoactive substances get released from that nerve ending where the nerve says, quit pushing on me, tissue. And then the nerves change their firing processes. And I like to say that a nerve is coming along like this. And then when we start to irritate it by neurotransmitters or swelling or it being pushed on, it fires erratically. And when it starts firing its signals erratically and propagating erratically, this is when we start to have pain signaling. And in a way, it doesn't really matter sometimes if it's acute versus chronic because they both are affected by nerves having this erratic firing. So a lot of people say that acute pain is a very specific injury. It's mechanical, it's inflammatory. You can identify what causes it. That is kind of true. It is true. It's mostly inflammatory. It is a nociceptive pain. And then we say, well, the transition to chronic pain is when that acute pain didn't resolve. Kind of true. We still say that. And in the hospital, that's probably 4 to 6 weeks. And then we say that both acute and chronic pain tend to be non-cancer pain, and they're not a rapidly progressive pain. And that is very true of acute and chronic pain. They're both more of a slow onset, consistent pain, whereas cancer pain you can identify because it's very rapidly progressive and you see it develop and worsen pretty quickly, usually as the tumor mass grows. Now, what is this slide? Why am I putting up a teeter-totter right in the middle of our talk? I'm putting up a teeter-totter in the middle of our talk to talk a little bit about this inflammatory component. So this, again, very cartoony, like we said, a whirlwind tour through pain, very basic. But when you have the mu and the delta receptors, these are opioid receptors, right? So let's move into the world of opioids involved in acute and chronic pain. There are several receptors in the opioid family. There's the mu, there's the delta, there's the kappa, there's the gamma, and there's the sigma. And the sigma, kappa, delta, mu all have very different roles. In general, the mu is kind of like the papa figure of the family. So the mu receptor is our main opioid receptor. It is the one that when we bind an opioid to it, it depolarizes and it produces analgesia. It is almost exclusively 90% found in the central nervous system, meaning the brain and spinal cord. There's a little bit of mu receptors in the periphery, in the stomach, and in the gut. And that is why when you take an opioid, say OxyContin, fentanyl, Vicodin, Percocet, you can get constipation because it binds some of those mu receptors that are in the gastrointestinal system, causing your peripheral system to slow down. Then we have the kappa receptor. The kappa receptor is the one that does a lot of the euphoria from opiates, kind of the high, the feel good, the sense of like, here comes my wave of pain relief. Those also lie what we call supraspinally or centrally in the brain and the brain stem. And then there is the kappa that also have a subset that do a little bit more with opioid resistance. We're not going to talk about those today. And we have the gamma. We're not going to talk about the gamma, but we are going to talk about the delta. So the delta are a small subset of the mu receptors, and the delta have a big part in inflammation. By themselves, they don't. But one of the emerging theories in acute and chronic pain and cancer pain, all these pains, is that the mu and delta need to be balanced. And most of us go through life with our mu a little bit heavier on that teeter-totter than our delta because we have our natural opioids, right? Those are our endorphins. That's our dikephalins, our dynorphins, dystropins. Those are our feel-good hormones. The first sip of coffee in the morning, the good feeling when a movie ends happy, the first bite of a chocolate bar. Those are endorphins being released. A lot of people say endorphin release is what runner's high is. When a runner's running and they get into the good part of their run and they feel really good, runner's high is an endorphin release. So most of us live with a little bit more mu blocked because we've had those endorphins. But then as we've gone through society and given people pain tablets, we block more mu, endorphins and mu, and the teeter-totter starts to get like I'm showing you in this picture now. And one of the thoughts about controlling inflammatory pain and post-op pain and pain down the road of chronic pain is to bring this teeter-totter back into balance, to take away some of that mu blockade so mu and delta are a little more balanced. And when you balance mu and delta, you balance your immune system. And when you balance your immune system, it seems to see that you balance inflammation a little better. We think inflammatory pain and inflammation is balanced very carefully with the immune system through some of these mu and delta receptors. There is one agent that's very good about providing just a tiny, tiny, tiny bit of a block of mu so that mu can say, I'm a little bit blocked now, so I'm not totally blocked. So my teeter-totter end is coming up and I balance delta. And that is, wait for it, low-dose naltrexone. So low-dose naltrexone is becoming a big player in pain medicine because it has a very small amount of mu blocking. Low-dose naltrexone came out in 1984. It's a very old medication, and its doses in those days were anywhere between 50 and 300 milligrams per day, used for obsessive compulsive disorder. It was its biggest claim to fame in the 80s and 90s. And then we started discovering that if we don't block mu tons with this low dose naltrexone, but just a baby bit, we allow that teeter-totter to balance. And so we use what's called low dose, a small amount, which is 4.5 milligrams per day or 2.5 milligrams per day. And it's a really nice, pure opioid antagonist at the mu receptor, and it brings our teeter-totter into balance. Now, we also know that low-dose naltrexone is good because it has a short half-life. Its half-life is only 6 hours. And the beauty of it only being 6 hours is that if you need them to stop it during the operating room, stop it during the hospitalization, stop it after surgery, you've only got to wait about 6 hours and it's out of your system. And there are times when we do need to stop it because remember, even though it's low dose, it's blocking some of those mus. And sometimes when you're in the hospital or in the perioperative state, we need those mus all open so we can bind it with something else like OxyContin or fentanyl or Percocet or Vicodin, and we don't want mu there. But in general, around here, we kind of like it when our patients are on a little bit of low-dose naltrexone because it kind of balances that propensity for inflammatory pain. So that's kind of your first little blibbit of a tip for perioperative pain management. Now, your second little blibbit or tip here is opioid trends. So in our institution, we're kind of getting away from long-acting opiates. And I'm by no means saying you need to do that or that's the right thing to do. That's just kind of what we are doing here, just what we do here in Oregon. We tend to get away a little bit from our long-acting and we're kind of just sticking to short-acting opioids. And the reason why is there's no scientific evidence to this that I'm aware of, but we understand there is a little bit of practice trend, and you can see some of my references below, then, it's sometimes a little bit easier for people to wean and acclimate to their short acting and go up and go down, keeping their doses overall lower when they have those short acting tablets. Because long acting tablets are really hard to go up and down on because they're so long acting. So we try to do only short acting, and we're moving towards buprenorphine. Now, buprenorphine, your other third little tip here, is not naltrexone, but it's similar to naltrexone. Naltrexone is just a pure blocker. Buprenorphine is a mixed blocker and a mixed agonist. So it is like naltrexone mixed with a little bit of Percocet. So it's got a little bit of blocking at the mu, but it also binds the mu to do pain relief. So it's kind of that perfect combo drug that, unlike just naltrexone, which blocks but doesn't give a lot of pain control, buprenorphine blocks and also gives pain control. And that's why we like it. And we used to use it mostly for what we call MAT, M-A-T, medication-assisted treatment. But now, as probably almost all of you are aware, we have moved into using it for pain in general. And so we don't just use it for MAT, for people who have gotten into a little bit of trouble on their opioids, or unfortunately we're using illicit substances from the streets or elsewhere, but we use it for pain management. And there's some little tricks with it that you probably want to know when you're in the perioperative setting. So that slide is coming up. But before we go over the tricks, let's go a little bit about where did buprenorphine come from and how did it even get so popular in our pain world? Well, it's a very, very old drug, older even than naltrexone, which came out in the 80s. This one came around in the 1960s. And when it came around in the 1960s, it was mainly used in laboratory research. And then in 78, Europe, in the UK, the United Kingdom, introduced it as an IV opioid analgesic. And it really became quite popular, was a hit. So we brought it across, we jumped across the pond over here to the US from UK, and the FDA decided to approve it as an injectable. Kind of interesting because usually we don't get injectables first. We get oral tablets first and then injectables. But the FDA approved it. And the FDA said, all right, we're going to give you an injectable medicine called Buprenex, which is buprenorphine injectable, and it's a Schedule II class opioid. And it just didn't take off. It sat around. No one really used it. And then 2002 is when the federal government was starting to see opioids were getting bigger and bigger, and we were controlling more pain. And It was the fifth vital sign. You guys probably remember those days. And that's when we kind of said, all right, we need to get something to help with problems when people get in trouble with their opiates. And that's when we brought it out as Suboxone, which is naloxone, a pure antagonist like naltrexone. And we brought out buprenorphine and naloxone as Suboxone, and we brought out Subutex, which was a sublingual buprenorphine. And we made them Schedule 3. And we made them Schedule 3, which says, oh gosh, they're not quite as controlled. They're a little less controlled, kind of encouraging people to use them. And then we said, gosh, all these people are getting Suboxone and Subutex when they're trying to get off their opioids, if they have some opioid use disorder or opioid dependence. What about our chronic patients who just want it, who want to be on it for chronic pain? And that's when we came out with the Butrans patch. And that came out in 2010. And that was mainly designed just for chronic pain. So we used that then. And then in 2015, buprenorphine in the form of Butrans was so famous that they came out with Belbuca, which was another form of buprenorphine for chronic pain, but not in a patch. It's kind of for more severe pain, and where buprenorphine Butrans was kind of middle of the road pain. And the history about buprenorphine is interesting and important to know, because you need to know that it started really as an IV drug. Then it went into opioid use disorder and MAT, medication-assisted treatment. And then it came back around for chronic pain. And now it's kind of honestly being used a little bit for everything. We're actually just using it for pain management now, because its beauty is that it does have what is called a ceiling effect on respiratory depression. So when you're on buprenorphine, it's a little bit safer for stopping or depressing or lowering down your ability to breathe when you're on opiates or when they're mixed with other meds that could affect your breathing. So we really try to encourage everyone to be on buprenorphine, and we use it tons in the perioperative setting. Now, I told you I was going to give you a tidbit about why it's challenging. Buprenorphine is challenging. And it's challenging because, unlike naltrexone, which sets on that mu receptor for just a few hours, buprenorphine sets on there for like 5 days, for 72 hours, and it holds like no other. The strongest binding medication to the mu receptor is buprenorphine. It really, really, really hangs on. And it hangs on so tightly that if Jane comes out of that appendectomy and she's like, oh my gosh, I really hurt. I know I shouldn't hurt so much. It's just a tiny incision, but I really need fentanyl. And you're in there giving fentanyl or morphine or hydromorphone dilaudid. You can't bump the buprenorphine off of the mu to get the fentanyl onto the mu. So one of the new recommendations now is not to try to bump that buprenorphine off before surgery. It's not to stop it and then hope that it's out of their system, but it's to kind of bump it off and add to it in a more gentler way. So what we do now is we leave people on their buprenorphine perioperatively. And we say to Jane, Jane, you're taking your regular buprenorphine. This was a small surgery. Let's just increase your buprenorphine. Because remember, it blocks and it's an analgesic and it depolarizes. So it's going to give her pain relief. It's a pain drug as well as a blocker. If she needs just full traditional opioid agonist, then we need to do something strong because we have to block that. So then we do lipophilic opioids. So we do things like fentanyl, alfentanil, remifentanil, sufentanil. And we have to use adjuncts like ketamine, which we're going to talk about here in a second, and other meds. And when we add some regional anesthesia, we may put in an epidural, we may put in a peripheral nerve block, we may put in a scalene, we may put in a ESP catheter, we may put in a sternal block, who knows, some type of PEX1, a PEX2, some type of block to kind of help her because that opiate can't fully get on the receptor. But studies have shown it's much cleaner to leave people on their buprenorphine and just keep giving it to the hospital and add things on top or increase the buprenorphine than it is to try to take them off, give them stuff while they're in the hospital, and then put them back on buprenorphine when they leave the hospital. That's a hard thing for our patients to do. Now let's talk about PCAs. I'm going to switch you now. So people say, okay, that's all great, Kim. You can give them oral buprenorphine. You can give them your oral naltrexone. You can do your blocks. But what about the patient who can't take oral, right? That's a big part of our patients in the hospital in the perioperative setting. We have a lot of people who have had esophagectomies and Whipples or, cancers of the upper GI system and they can't eat or drink, or they're having bowel cancers and bowel surgeries and they're on feeding tubes and G tubes. So the PCA is a really good tool. And I know a lot of us get scared of patient-controlled analgesia because we worry about our patients overdosing or having a problem. But actually, a PCA is very safe. And it's very safe in a couple of ways, and it has good evidence in a couple of ways. Now, one of the main ways it has good evidence, and I'm going to kind of talk about one of its safety and one of its good ways. I don't know that I'll get through all of the history of this, is that they have done studies. And when patients have a PCA at their bedside, as opposed to calling the nurse, even though our nurses are great and the nurses bring in breakthrough hydromorphone and breakthrough medications, we have found that the better satisfaction and the higher patient satisfaction comes out of control at the bed by themselves, having a push button. So those studies are very definitively done that having a PCA is more happy for your patients than having the nurse come in. And the nurses tend to like it too, because when they get busy, they don't have to feel bad like, oh gosh, I couldn't get into that room as quickly as I wanted because I had 7 other patients today. And we all know healthcare is kind of strained without as much help right now. Getting better, but still pretty short. So that's one of the good evidence ways I mentioned that it has a history of showing that it's beneficial. The other safety thing about it that it shows that it's safe is if you don't put on a basal rate, a continuous rate on a PCA, they are pretty safe. You just have a continuous, every 7, every 10, every 12, depending on the metabolism of the drug you're giving. A patient technically pushing the button here, I'm mimicking that, should fall asleep and their thumbs should fall off the button and they should let the button drop when they have enough sedation and enough meds on board. They shouldn't be able to over sedate themselves on an opiate with the button only on a continuous. And when you look at some curves, this is taken from some of the anesthesia literature on pharmacology and physiology, you see the analgesia is there in the blue curve. And the red is what happens when a nurse brings med. They go up, down, up, down. That's the PRN dosing by a nurse. They get over the analgesia amount and over sedated. That's the curve going above the little blue with the 2 black lines on it. And then when they're waiting for the nurse to come and she gets busy or he gets busy, they kind of get behind. But a PCA stays, that's the blue line swiggling up and down there, stays right in between those good analgesia lines that we like. That's above the line that has pain, but below the black line of respiratory depression. And so we use a lot of PCAs in our institution. It gives patients a chance to have some autonomy and authority and ownership. And you're very vulnerable when you're in a hospital, right? People are waking you up. You're half kind of naked in these really thin gowns. You haven't brushed your teeth and you can't get a good shower and you're not eating what you want to eat. And so having some element of control goes a long way just to control the pain itself without even medicine in the PCA. They've done studies with just saline in the PCA, and just having that control at the bedside helps. So we do a lot of PCAs without a basal rate. Okay, next little tidbit. Here comes your World War tour. I don't know where we are. We're around to Africa maybe by now in the world on our world tour here. But how do you calculate? So people say, okay, Kim, fine. We're going to give your PCA idea you're telling us about. But at some point, I can't send them home with a PCA. They're not going to go home with an IV and PCA. So how do I convert? How do I convert their medications to something they can go home with? This is tried and true. There's a lot of different ways to do this. This is just from some literature out by MD Anderson Cancer Center, but there are many, many, many references on this. But one way that we do it, it's a pretty simple way, is we take everything they used, what the nurse brought in, what they used off their PCA, what they took oral, and we just tally it up in one big bag and say 100 milligrams, just all there. And we take the whole 24 hours and we convert to morphine first. Morphine is the easiest way to convert first, to convert it to morphine, because morphine has the cleanest conversion tables, right? We know what morphine to fentanyl is, morphine to oxycodone is, morphine to butrans is, morphine to remifentanil is. So we put it all in morphine, one little big Santa Claus grab bag here of stuff, of toys, and then we convert it to the agent we want to use, right? And whenever you convert from one medication to another, so you got all this IV med and it's 5,000 milligrams and you converted it to IV morphine. Now you convert it over to PO morphine. And then when you make the new drug, you always reduce the dose. And people say, isn't that mean? Why, Kim, if you needed 10 milligrams, are you starting me on 5? And I'm like, I'm starting you on a lower dose because there's something called cross tolerance, where a new drug may work much better and you may have less tolerance for it. And so to keep people safe, we need to drop it. So always drop down by 25 or 50% when you pick your new agent, and then start that when you wean off your PCA. And we do that all day long. And we always try to keep the PCAs on for at least 24 hours because a 24-hour collection cycle is a good cycle to be able to gather all the opioids together in 24 hours. And then day 2 or day 3, or however long you want to leave the PCA on, but at least 24 hours, you can convert to the new drug and calculate the oral dosing. Okay, gabapentin. I love gabapentin. Gabapentin is generic. Gabapentin doesn't cost much. And there are worlds and worlds and worlds of studies on gabapentin and everything it does. And I'm not going to go through all of these studies. You can read them all. I put a lot of references here for you. But gabapentin does so many good things. Why not try some gabapentin every time, every surgery? We do. We do low dose just because a lot of people are naive to it. They haven't had it, but we give people 100 to 300 milligrams in pre-op for every case before they go back, before the incision happens. And we use it a lot in the post-op recovery. And really the 2 main things we worry about with gabapentin is if they're having side effects, of course, we stop it. If they're elderly, we're careful because it can have cognitive dysfunction. And if they have any renal insufficiency, we're careful because there is some dosing for gabapentin for renal insufficiency. But gabapentin is this wonderful, wonderful anti-neuropathic agent. So it works for nerve pain, but it also, we know, works a little bit for nociceptive and inflammatory pain. And it's pretty innocuous. It doesn't lead to too much sedation with opioids given on board with it. It can be start and stopped pretty easily. If someone has seizures, you need to watch a little bit about going up and down on it because it does affect seizure threshold. But otherwise, it's very, very safe. It's very rare to have allergies to it. So it makes everything else work better. So we always kind of say you can drink water, or you can drink water with a little Kool-Aid in it, so it tastes a little better. And gabapentin is like that little Kool-Aid. You pop in your mixture in the hospital just to make it a little bit more fun, your pain management, and a little bit better. I guess that's dependent on if you like Kool-Aid or not. And then people say, pregabalin, how about pregabalin? Well, pregabalin, we used to call it the new and improved gabapentin, right? Pregabalin is Lyrica. Gabapentin is formerly known as Neurontin, still called Neurontin, but there's a lot of generic and other brand names now too. Pregabalin has a little bit of a different dosing, and I'm going to let you read this slide to yourself, but I'm not going to read it out loud. But the main thing to remember about pregabalin and how we dose it is that it's more potent. It's a little bit more bioavailable than your gabapentin. So you can get to higher doses more quickly. And in getting to higher doses more quickly, you can usually get more effective pain control. And because it's more potent and you can get to higher doses more quickly, you also can change its dose more quickly. So you can go up more quickly, get to higher doses, and change whatever dose you're giving more than every few days like you do with gabapentin. The couple things to remember is that you really shouldn't get pregabalin and gabapentin together because pregabalin's only really been studied at a top dose of 600 milligrams per day, where gabapentin goes much higher. And we don't really have a lot of studies of the 2 together and how safe it is to mix the agents, even if you're staying under 600 of pregabalin. What we always say clinically, and I don't have a study for this, so this is just Kim's clinical thoughts on her experience, is pregabalin is the good and the bad of gabapentin. That's how I look at it. If gabapentin didn't work and have a lot of side effects, pregabalin could work because it's more potent. But if gabapentin had side effects and those were its bad side, pregabalin is going to have more side effects because it's the good and the bad, right? It's the bad side of gabapentin as well. However, because you can get away with lower doses because it's more potent, maybe you can avoid those side effects because you can use lower doses of pregabalin than gabapentin. And then the good of gabapentin is easy. If gabapentin works wonderfully, pregabalin is probably going to work even better. So those are the main patients I move to, is when they're doing okay on gabapentin, I'm like, aha, they're going to even do better when they have pregabalin. But if they're doing kind of bad on gabapentin, I usually don't try pregabalin because it's similar enough of a medication that they're probably not going to like it either. But that's just a big generalization of mine. I don't want you to take that too much to heart. So we talked a little bit about pregabalin and gabapentin and PCAs and naltrexone and naloxone and buprenorphine. And what about, and we kind of talked about how pregabalin, is it better than gabapentin? We talked a little bit about that. What about antidepressants? Well, antidepressants are great, and we don't use them as much in perioperative medicine or medication trials as we do the others. And the main two reasons why we don't, and again, this is what my institution does and my experience, you may have a very different setting, different patients, and a different experience, is because the antidepressants take a while to get effective. You have to ramp them up slowly, and they really take being on them for a good 4 to 6 weeks till you actually know how they're going to work for your pain. And most people aren't in the hospital that long, thankfully, to see the effects of their antidepressants. And the other thing about antidepressants that I don't take lightly, antidepressants are hard to go onto and hard to go off of. And they're a very specific medication. I can't tell you how many times in a week a patient comes to me and says, Kim, whatever you do today at my appointment, please do not change my antidepressant. It took me 10 different trials of 10 different medications and 10 different years to find one that doesn't have side effects and that I like it and it works. So please don't mess with it. And I'm like, okay, totally fair game. So antidepressants, we use them, but I just want you to think about it. They're a bigger ask of your patient to commit to this, especially in a hospital. You're putting them on something that really needs to stay on long term, does need to be weaned slowly when you take it away, does take a long time to work. And, it has a lot of effects. There's serotonin, and serotonin can make people feel really yucky, really good, kind of manic, really depressed. It can have all kinds of different effects. And the tricyclic antidepressants are really old antidepressants that the psychiatrists and counselors and psychologists don't use for depression anymore, but we still use for pain. We use in lower doses, but we're very carefully using them in our elderly patients because they have a lot of side effects, a lot of side effects. Duloxetine is probably one of the better ones that has been shown to have a norepinephrine sparing effect, which is a whole nother talk about norepinephrine and pain and duloxetine, but that's a good one for pain. It's not new anymore, but it's a very good pain one. Venlafaxine is a Fexer. That's a good one, but you have to get to high doses to see its pain effect. And then the SSRIs, meaning the ones that aren't the SSNRIs, so the meaning they affect serotonin, but not norepinephrine and serotonin, they don't work as well. So we don't use a lot of the SSRIs. We use a lot of the SSNRIs because one of the neurotransmitters or agents you need to affect in the body with antidepressants is norepinephrine. So you want an antidepressant that reuptake inhibits norepinephrine, not just serotonin. So we don't use these a lot, but I mention them in this talk because they are a big player in the perioperative world. And I will say the one thing you don't want to do is stop a patient's antidepressant because they will start feeling kind of groggy and sometimes sleepy and not themselves. And sometimes that's just because they're missing their home antidepressant dose. So remember that. The hard thing in the US is we don't have these IVs. So when you have patients who take an antidepressant at home and they can't eat for several weeks or days in the hospital, and we don't have a way to give it to them, it kind of does start affecting their pain control and their mood. Now, I know we talked a little bit about opiates, but I wanted to put a little bit about nonsteroidals in here. I have a whole different talk on nonsteroidals, but just to let you know that across the board, in general, a major big generalization, but probably okay to do it here, is that they're really pretty equal in reducing pain. And I just always tell our trainees that in the hospital, like, if we're picking, I'm going to start with a nonsteroidal. If I can, there's times when people cannot have nonsteroidal agents if their renal function is declined, if they've had a big bone surgery. A lot of surgeons worry about bone healing when they have a nonsteroidal on board. They have an allergy, if they have nasal polyps, if they have gastric bleeding, an ulcer history. So there's a lot of reasons they can have nonsteroidals. But if you can, just kind of remember across the board for neuropathic pain, cancer pain, inflammatory pain, nociceptive pain, visceral pain, all these types of chronic pain we talked about and acute pain, they're pretty equal to opioids in reducing pain. Studies pretty much show that. And then there's ketamine. Everyone loves ketamine now. We use ketamine quite a bit in the hospital. Ketamine used to be an anesthetic in the 1960s, and then it kind of moved from being a general anesthetic to going to the ORs and to the sedation units in ORs or to the ICUs, and the anesthesiologists used it just for sedation or to get a couple minutes for their patient to kind of relax and chill out when their patients were feeling very stressed. And then it kind of started becoming used in emergency departments. So now they use it like to set a broken bone in the emergency department. And now they're using it, our emergency medical personnel out in the field, if they have to put in an IV and someone's really scared or someone's kind of being wild and uninhibited due to whatever. So it's used a lot in a lot of different places. And now we have a lot of good indications, or fairly good indications, that it can help in depression and some psychiatric comorbidities. So we're seeing our psychiatrists use it. And in the hospital, it's very good for acute pain. There's a lot of really good studies that it helps for acute pain. In the chronic pain world, I just want to tell you the literature is not very well solidified. It's not very well solidified as to the dose, or how long it works, or how much it should cost, or how often you should do it, or what conditions you should use it for. So we're not using it for chronic pain here at OHSU, just for acute pain in the hospital. There's a little bit of evidence for CRPS that ketamine can help in some certain chronic pain conditions. But by far, mostly stays in the hospital as a perioperative and acute pain regimen. So not so much in the chronic world, although there are a lot of ketamine clinics in the chronic world where patients can go get ketamine, not covered by insurance mostly. So it's a mostly a cash pay mechanism for those patients. And then I'm going to get to the end of this talk with just a tiny bit about acetaminophen. You know, people say Tylenol. I can't believe you just gave me an appendectomy. This is what Jane may say to me. And you're giving me Tylenol? I'm like, yeah, I'm giving you Tylenol. Well, Tylenol is kind of weak as an anti-inflammatory. And if I've just sat here and gave you a 45-minute lecture on how a lot of acute pain is inflammatory, why in the world would I give you Tylenol when I'm telling you it has weak anti-inflammatory effects? Well, I'm giving you Tylenol because it's like that Kool-Aid. Tylenol makes everything work better. Tylenol is that silent partner in the background that always has your back, that's there working, and you don't know about it. So Tylenol makes opioids work better. Tylenol makes non-steroidals work better. Tylenol makes your antidepressants work better. Tylenol makes your lidocaine patches work better. Tylenol makes your PCA work better. Tylenol makes your ketamine work better, and it's pretty harmless. So we use a lot of Tylenol. And you do have to be careful in liver dysfunction, of course. That's always a big one, but we use a lot of Tylenol. We have IV Tylenol, we give rectal Tylenol, we give IM Tylenol, we give oral Tylenol, we give nasal Tylenol. So Tylenol is just kind of one we always put on board. It's like the little pot always at simmer. It's already hot, kind of waiting for you to boil so you can cook your food. It's always there. It's ready to go. And so we use a lot of Tylenol. I think it's a very easy agent. It's very safe to incorporate into your perioperative setting. I do say make sure you stop it when they go home, because we don't want people going home and taking bottles of Tylenol. So we just use some of these things like the non-steroidals and the Tylenol while they're in the hospital. But it's a very good agent, and we really, really like it. Now, last slide here. What do we need to be careful of? We need to be careful of a couple of things. When you're in the hospital, watch your benzodiazepines, your Verseds, and medications like that with your opiates. They're very synergistic for sleepiness and respiratory depression. Also watch some of your buprenorphine, which is your mu blocker and your agonist, with other agonists, because when you're mixing all that together, at some point, you're mixing, and the patient's in the hospital more than 5 days, and you're not giving them buprenorphine. That buprenorphine is going to go away, and all those mu receptors are now unblocked, and you can get a really sedated patient. So be careful with the buprenorphine mixed in with pure agonists like fentanyl and OxyContin and oxycodone. And really watch out for baclofen withdrawal. That can cause life-threatening AFib or a flutter. It's very dangerous to patients. So people are on baclofen, please keep their baclofen going. If they have a baclofen pump, please keep it going. Keep their oral baclofen going. And then be careful with basal rate PCAs, because if you've just got the push button with only demand and they get sleepy, they'll quit pushing. But if they fall asleep because they're over sedated and you have a continuous rate running, you may have some problems with your patient overnight, or they've already fallen asleep and now you're still giving them meds and they don't need any more and you've still given them meds. So be very careful with a basal or continuous rate PCA. So now I think we're going to move into about 15 minutes of questions, and I am going to turn the floor over to all these wonderful people from the American Heart Association that are helping.
Thank you so much, Dr. Maurer, for that great presentation. As a reminder to our audience, you can still submit your questions for this speaker using the questions feature on your control panel, and you can submit them at any time and we'll collect them and ask them aloud as time allows. So Dr. Maurer, our first question is, could you please review again when to use naltrexone versus buprenorphine one more time?
Yes, was the question, I'm going to repeat it. When to use naltrexone versus buprenorphine?
Yes.
Okay, very good. So if they're already on buprenorphine, that's a no-brainer. Keep using buprenorphine. If they're not on anything and you don't think you're going to need a lot of opioids during their hospitalization, just use a little bit of low-dose naltrexone for pain. But I would never stop someone's buprenorphine to put them on naltrexone, and I wouldn't start buprenorphine as a first-line agent. If I was going to start something, I would use naltrexone before buprenorphine. Buprenorphine is a bigger ask of your patient and a bigger commitment. Hopefully that kind of answers it.
I think that's what their question was. Thank you for that clarification.
Okay.
So next question, should all patients receive gabapentin preoperatively and at what dose?
In my personal view, I think yes. I would give everyone, and I would give them somewhere between 100 and 300 milligrams on the day of surgery, just with a sip of water. And you can do it, have them do it at home before they come in, or have them do it in the pre-op holding area. My elderly patients over about 65, I just give 100 to, and everyone else I give 300 to. And even just one dose before surgery, even if you don't continue it after anesthesia or after the surgery, it's been proven to help. So my answer to that question would be yes.
Wonderful, thank you.
You're welcome.
Can you comment on the role of the multidisciplinary team in perioperative pain management?
Oh, huge, huge. I didn't even go into that in this talk, but we're really blessed out here in Oregon. The people really love all the multimodal aspects of pain, the naturopath, the acupuncture, the sleep medicine, the massage, the rolfing, the chiropractic. We have all of that. And we also very much work in teams. So, I know we're very blessed in that I have a big institution, but we have a team that we use for opioid use disorder and other disorders that works with us. Plus we have a palliative care team, plus we have a hospice team. And multidisciplinary pain is the best way. Keep everyone on the same page, be involved, talk to your surgeons, get as many alternative things in. We have acupuncture for our patients. We have massage in the hospital. Herbals can come into our hospital as long as they're ones that seem pretty safe. Definitely, hands down, better pain control with the more modalities and the more multidisciplinary specialists you bring in.
Thank you very much. A question that I think ties in nicely with that one. You had talked about acupuncture. What is the importance of modalities such as acupuncture and relaxation techniques prior to surgery?
Super important. So the thing to remember, at least in my understanding of all the complementary surgery pieces like acupuncture and massage and rolfing, is we may not always have a lot of studies or data that says this much reduction in pain or do it for this many times a week times this many minutes. But we have a lot of safety studies. We have a lot of safety studies that these things aren't going to hurt. We may not know exactly how much they were going to help, but we know for sure they're not going to hurt. So I would say bring in as much as you can. We do have people start acupuncture and mindfulness and biofeedback. We do some hypnosis. As much as they're willing to do, as much as their insurance will cover, and as much as they can get access to those resources, we try to incorporate before surgery, during surgery, and in the hospital. Oregon has a lot of rural areas. So where I live, if you're outside of Portland, sometimes it's hard to find providers in those modalities, but if we can, we definitely employ them.
Very good, thanks. So given that APAP can work as an adjunct to augment analgesia, should it be scheduled? And what should that dosing be? Or should it be as needed, PRN?
We schedule it. And we stay under 3 grams a day with normal liver function. We used to do 4 grams a day. And then there was a study, gosh, it's been a while now, but it kind of came out saying, maybe 4 grams is a slight bit much. Although I know a lot of places still do 4 grams. I think that's okay, but we do no more than 3 grams a day. And we do schedule it. And so we do something like 650 milligrams every 8 hours or 350 every 6 hours. And we schedule it around the clock. Of course, if a patient doesn't want it scheduled, we don't. And scheduling it, just make sure they get it. And it's one less thing the nurses have to go in and ask about when they get busy, if it just kind of comes with the regular meds. So I do think it's a great thing to schedule. I think it's pretty safe. And then we take it off their MAR and we don't send them home with it, but we do it regularly while they're in the hospital.
Thank you. What are your thoughts on use of other topicals such as lidocaine patches or gels?
I love them. I love them. I use them like crazy. We have on our formulary at our hospital here, we have diclofenac gel and diclofenac patches, and lidocaine gel and lidocaine patches. And we can get in our hospital a mixed lidocaine, amitriptyline, ketamine cream. That's a specialty cream that we use. The couple of things to remember is that a lot of things can't cross the skin. And the skin is our largest barrier. It's our largest organ. And it is really protective of our insides, which is a great thing. So, gabapentin in creams, it doesn't really cross the skin. So we don't use gabapentin or Neurontin creams. And a lot of the muscle relaxants don't cross over the skin. So we don't use many muscle relaxant creams. But lidocaine, the TCAs like amitriptyline, and ketamine cross really well. So we use a combination of a lot of those. And I pretty much put those on everyone, some type of patch over their incision or a cream on a painful area with the Tylenol. I dose it. So when they get their Tylenol, they get one of their creams or their patches. Try to coordinate the timing. It's not as often as the Tylenol, but try to coordinate it with one of the Tylenol administrations so that it's scheduled. It adds another component that will let you use less opioids and less ketamine. And you have kind of these nice, smaller, low side effect profile things in the background.
Thank you for that perspective. So we have one more question around pain assessment. I guess it's a two-part question. So at what stages in the perioperative pain management journey do you incorporate pain assessments and reassessments?
That's a very good question. So we try in our preoperative clinic, if they come through the preoperative clinic or they're seen with the surgeons in pre-op or with our clinic in pre-op, to do some questionnaires. And we like to collect the BDI, and we like to collect the Oswestry Disability Index. Now, I am not an expert in secondary and primary measures to know which one's the best, but that's kind of what we collect. We like to collect the BDI because it includes some mood around pain. And we like to collect the Oswestry because it collects some around function or disability or lack of ability to participate or move. And then we collect them once while they're in the hospital. And then we try to get 2 collections when they leave the hospital, one at the immediate post-op visit and then one later on. And it really does show us that our work is working. And we do this really to show that, because sometimes we need it to get the covers or the insurers to pay for things. So we collect it 4 times, pre-op, right in the hospital, and a couple times after the hospital. And I don't know if it matters what you collect. I know a lot of people are using the PROMIS measures. We sometimes use the PROMIS 7 as well.
Wonderful. Thank you so much. And actually, you answered the second part of that question with your answer there. So we're concluding our Q&A now, and we will turn it back to David for some closing remarks. Thank you so much.
Thank you.
Well, thank you, Dr. Maurer. That was a great discussion today. And thank you for the audience for contributing to the discussion. When you exit the session, a feedback survey will pop up in your browser. You will also receive a follow-up email tomorrow with the survey. The recordings from today's summit will be available in the coming weeks at heart.org/pain management. Please be sure to visit this site for additional resources on this topic and join our mailing list. Coming up at 1 p.m. Central, we have Heart, Brain, and Pain, Unraveling Headache in Vascular Health. To access, please exit this session, return to the lobby using the menu at the top of your screen. From that lobby, click on the Sessions tab first, and then second, click on the individual session to join. Thank you very much for attending this summit. We'll see you shortly.